right. Good afternoon. Thank you all for being here. My name is Rebecca Whitaker, and I am a research director at the Duke-Margolis Institute, where I help lead our work on North Carolina and kind of state-based healthcare innovation and Medicaid transformation. So I'm really excited for our panel this afternoon and joined by my friends and colleagues. And I think we'll really be picking up on a lot of the themes that we've heard from prior discussions today, an emphasis on upstream interventions and community-based approaches. So really integrating that into this session on healthcare reforms to support healthier and resilient communities, learnings from North Carolina's Hurricane Helene response. So I think everyone is well aware that extreme weather events are causing major disruptions across the country. We were just talking about fire and extreme heat in the previous panel. And this comes at a time where community resources are strained and individual health risks are on the rise. So communities are being asked to do more with less. Hurricane Helene's impact on Western North Carolina, which occurred just over a year ago, provides a stark example of some of these challenges, but it also revealed the power of community and partnerships and real-world examples of innovative health and social care delivery models, which we spoke about a little bit during the previous session. In particular, the North Carolina Healthy Opportunities Pilots program showed how collaborative, proactive approaches to community health infrastructure can both strengthen community resilience as well as emergency response capabilities. So in this session, our panelists will discuss feasible policy reforms with the greatest potential to foster local preparedness in the face of climate-driven emergency events. Crucially, these policies, as we know, must be evidence-based and emphasize non-partisan work to address specific local healthcare challenges presented by climate change. So all of our speakers here today have experience with Western North Carolina's Hurricane Helene response, and we're going to hear from their perspectives on scalable and sustainable strategies that address social and environmental drivers of health. So first, I am going to come to you, Cody, as the former secretary of the North Carolina Department of Health and Human Services. You were charged with leading implementation of a lot of North Carolina's healthcare transformation efforts at that time, including the Healthy Opportunities Pilot. So if you could spend a few minutes telling us about the Pilots program, how it had bipartisan support, and how HOP, we call it Healthy Opportunities Pilots, HOP, facilitate Hurricane Helene response.
Sure. Well, it's wonderful to be with everyone today, and I just want to promise you that, just to spice it up as much as possible, I'm going to disagree with Bill based off no matter what he says. We've prearranged this.
I'm not sure I ended up in the middle.
Susan made the wrong choice of where she is seated, so we'll dive in here and keep this interesting, and we're really looking forward to having a conversation, so get your hardest questions ready. So Healthy Opportunities was born out of, I think, the basic belief that has been discussed and was discussed on the prior panel, especially that 80% of what drives health is generally not what we focus on investing in the health system. And how do we try to change the payment framework so that can be made possible? So North Carolina was approved, actually under President Trump's first administration, to launch the first in the country pilot of using Medicaid dollars to pay for food, transportation, a number of other services. And this pilot would lead the nation and really set the tone for what a lot of other states have done under something called the 1115 waivers for other states to try to mirror this effort. North Carolina's pilot program, though, is unique in a couple of ways. One, we have perhaps the most, or have had perhaps the most diverse number of services that were covered under a CMS waiver, right? Because our belief was we really wanted to try to examine which of the services that you invest in would make the biggest difference over time. And then the second thing was that we, to try to limit the spend in a state of now 11.6 million people, we were going to test in 3 pilot regions, so 33 of the 100 counties, by and large, our most rural parts of the state, which is, I think, a particularly bold decision, because this was made at a time when we still had not yet expanded Medicaid. We had over 1 million people uninsured, and so we were trying to bring forth to bear services for some of our most chronically ill individuals that we believed was going to really turn the dial at a place where we knew people were really behind the curve because they had lacked access or had been kind of gyrating in and access over the years. And so, fast forward, it took a little bit of a launch. There was some sort of viral pandemic situation, but took a little bit to launch. And when we launched, just 2 years later, and that's what kind of blew us all away. There's too many wind puns for hurricane. Blew us away that 2 years in, we had, statistically significant evidence on reduction in stated need. People's needs were getting met. Their ED visits were going down, and their hospitalizations were going down. To the point where, and those are, this crew knows, those are costly things. When you turn down the utilization of those, you can spend a whole lot of money on the upfront services, and you're still saving money. We were saving over $1,000 per year, which in kind of capitated rates for managed care plans is real money. And so I think that sets the table on that. I'll turn it over to the others, but just briefly say, I can't underscore how important it was to also have, and Susan and Bill can talk about this way better than I can, but having the ground game of relationships. I think that's another transformational part of North Carolina's story, is that we weren't just shipping food boxes to people in the mail. I love my postal carrier, but you were actually having people come to your door with fresh food boxes to build a relationship that would then turn from a conversation about food insecurity into a conversation about potentially interpersonal violence and getting a referral to another service and what that meant. It was also an economic driver of jobs in communities. And so that infrastructure, to have it on the ground when Hurricane Helene brought its worst, allowed us to have personal relationships that really showcased the best. And that's what was so transformative about it out of the gate.
Thank you, Cody, and definitely want to come back to some of those themes that you were pointing to in your opening comments there. But coming to you next, Susan, you're the president and CEO of the Dogwood Health Trust, which is a philanthropic organization dedicated to improving health and well-being in Western North Carolina. Can you share how the Healthy Opportunities pilots have impacted your work at the Trust and the efforts of the Trust to do this work in some of the more rural counties in our state as well?
Absolutely, and I just want to say thank you to Duke Margolis and everyone for setting the table for this really important conversation. We are a healthcare conversion foundation that was created with the sale of our hospital in 2019. That year's important because that was around the time that the Healthy Opportunities concept was being discussed and getting the waiver. Our foundation was really set up to focus on that 80% that Cody mentioned. We know that about 20% of what contributes to our health happens in hospital healthcare systems. That other 80% are these social drivers of health, non-medical related health needs. And so this was really a natural fit. I know earlier, Dr. Frist and others talked about the importance of public-private partnerships and how that can really drive innovation. And so Dogwood Health Trust was really privileged to partner with the state and contribute about $1 for every $2 of the state to get this network up and running. And we created a not-for-profit that really hired and then further developed deep relationships within the community. And that was really key. This was, from the get-go, started in a way that valued the deep expertise of community and built on that, and then capitalized off of relationships to get these social drivers delivered. So, housing mitigation was so important. We, have a story which you've probably heard so many of, where there was a child who was showing up in the ED every month for asthma. And when their home got mitigated for the mold and mildew, they came to the hospital one time the next year. The family with a woman with diabetes who is, we as I'm a physician and would give that prescription and say, go eat a healthy diet, right? Well, how do you do that? So to have a prescribed healthy meal come to their house every week made that real. They could get the kind of foods they needed to eat healthy. And so this was so important from one, getting those services to people to keep them healthy. And it was also important, and I know we'll talk about this a little more, building a network that not only gets the services, but builds from our local economy. So these foods that are delivered in the food box are grown by our local farmers. And that is key to really that economic benefit that you talked about. So this just made sense for Dogwood to be involved.
Absolutely, and I do want to come back to the network piece and sort of the kind of building that network and the hyper-local focus of that. But first, coming to you, Bill, as the CEO of the Mountain Area Health Education Center, you've decades of experience both practicing medicine, but also advancing health professions education in rural communities in Western North Carolina. So from your perspective, working with rural communities during Hurricane Helene response, how did the pilots really support healthcare delivery infrastructure in this critical time? And what aspects of the program do you see as really valuable for building community resilience?
Thank you for the question. And let me preface my comments by sharing a little bit about my background and what MAHEC is. MAHEC is one of many AHECs across the country. We're now celebrating our 51st anniversary, and I spent the first 3 years of my role giving a talk I called the What the Heck is MAHEC talk, because people don't appreciate what an AHEC is. And once you've seen one AHEC, you've seen exactly one AHEC. They are all wildly different based on unique needs of communities. It's a federal, state, and local partnership that began in the 70s, whose purpose was to put physicians in local communities to address the mismatch of providers and patients in underserved areas, not just rural areas, but that's where it started, and then also in underserved urban areas. And so we have a large GME program with over 250 residents in training. We serve as the western campus of the UNC Health Sciences, so we have third and fourth year medical students. The dental school has a footprint on our campus. We have the Gilling School of Public Health, and we have a 4-year pharmacy program on our campus. We're also a federally qualified health center, so we have a special charge to serve the underserved and underinsured folks, and we'll see over 300,000 visits this next year with roughly 60,000 unique patients. And I share that as a background so that you can appreciate the different aspects where as we carry on our conversation throughout the rest of the day here, where the policy implications affect us in many different areas along the spectrum of healthcare delivery, from job creation to direct service delivery. So your question was about the infrastructure and resiliency, and relationships. What I was most impressed when the storm hit and what beneficially impacted us was that the Healthy Opportunities pilot, which created this network of service providers with an infrastructure to get the needed services delivered, predominantly around housing and food, but other areas also. We could flip the switch because of its pre-existence to meet the exact needs that we had. Now, I don't think people fully appreciate just how challenging it was to communicate in the immediate aftermath of the storm, and that it's nice to have relationships and to have networks, but if you can't reach the people in the relationships or in the networks, it's a challenge. But if you don't have the relationships in the first place, then the communication issues become inordinately a barrier. And so that resiliency not only I think that was the creation of the resiliency, was having those networks in place to begin with, and then capitalizing on them, built on resiliency because we knew each other. And oddly, Cody and I met during COVID. That was a critical aspect of like an odd preparation for this, what faced us with the real physical storm of Helene.
Yeah, and I think, I want to be real clear and hone in a little bit on, what we mean when we're talking about this infrastructure to enable community resilience. I think we've talked about the networks and the communication and the relationships there. But Cody, can you help us take a step back even and kind of what do we mean by infrastructure in the context of community health and resilience, and what are some of the things that come to mind for you that maybe we haven't already talked about so far?
Hurricanes do an amazing job, especially disaster storms across the board, of really wiping away everything that we take for granted. And that's what happened in Helene. Bill alluded to the communication challenges from, literally there was a landslide that wiped away the fiber backbone to the Verizon and AT&T towers in Western North Carolina. None of that worked for a long period of time. And we had communities of people that were, independent living with disabilities and serious mental illness, who had no flushing toilets, who could not have their caregivers come and get to them, et cetera. And the folks that are most vulnerable and are living with chronic disease often have perhaps the least patchwork or the patchiest patchwork of natural supports in place already. And so to have something like Healthy Opportunities, where we had essentially a significant ground game of community health workers, local churches that were growing food, service providers that were going into your home and coming to visit you, a significant amount of trust. When we started to figure out, okay, well, and there was people had walkie-talkies, people were driving up to folks' houses. When we didn't have the phones and those sorts of things, we were doing whatever we could, both to do initial problem identification, to try to bring to bear, okay, are you getting access to food? Here's where food services are getting stood up. Here's how we're gonna, and to really be the cohesive infrastructure between what is normal, kind of the normal FEMA response, right? So we had semi-trucks positioned in Spartanburg that then started to come up the hill when 95 had restored access. We were landing these major aircraft at Asheville Regional Airport, which had 35 semi-trucks worth of food supplies and water that were then getting helicoptered out on these Chinook helicopters into every county. But all of that sounds huge, but it would still just go to one drop site in one of the western counties. And how did it get from there up into these hills? And for those of you that have been in Western North Carolina, I always like to say, a lot of people moved to Western North Carolina because they didn't want to be found. and so to even know where to go or how to, getting taken over, even know where to go or how to get to them and I just want to also be clear, and this is the cultural competency of this work, if you walk onto someone's property in Western North Carolina unannounced, that is a risky decision. And so to go up and knock on, I negotiated a truce with a militia in the middle of the storm too. We had some significant wild stuff happening, right? Yeah. And to be able to have a workforce of people pre-ingrained and connected, and to be bringing food, that was transformational, because all of a sudden having a whole lot of, whether it's National Guard or having out-of-state Red Cross workers or whatever, try to drive food from the little paddy wagon that was being dropped off, whatever, into your home, not going to work. And so I think that that's a fundamental difference about that sort of infrastructure. And we're kind of glossing over the basic fact, which is a lot of the, tragically, a little over 100 people lost their lives in this storm, and the folks who, many of them were from landslides and flooding. But for the folks who then died many days later, there were people who were struggling with chronic disease. Yeah. And so the folks that were tied into this program already were the ones that, when we needed to, in a flurry, try to figure out, okay, who's oxygen dependent? Who is due for dialysis? Right, who is living at home stably, but is only a few days away from being in a really bad situation. People who were tied into the HOT program were the ways that we could find those people faster. And frankly, where those people, the knowledge of them was disaggregated such that before I even had to ask, the community health workers were already going after them. Right. So I think that helps maybe frame up the infrastructure a bit differently.
Yeah, no, absolutely, and thank you, Cody. And Susan, I'll give you a chance to kind of build on that if there's anything you wanted to add there too, but I think, you know, as we think about those relationships, but also kind of the hyper-local nature of the pilots and sort of building these with community and in communities, contributing to a lot of the infrastructural resilience of Western North Carolina in response to the storm. So if you want to touch on that a little bit as well.
Yeah, and I will. I'm glad you brought up the community health workers and the folks like that, and that trusting, because yes, you do not go knock on a door in rural Western North Carolina if you're unannounced and they don't know who you are. And so I can't stress enough the importance of these community health workers, this network throughout Western North Carolina that are tied in to this Medicaid transformation project, were people who weren't community health workers already. They were developed out of people from the communities. They were one of the community. And when we think about the workforce in the disaster, we have to remember that you mentioned, 108 are on the books as, dying in the storm just for Western North Carolina. I think there are more that may not have met that definition, and over 120,000 homes and structures were damaged and lost. So you're in a community where almost everyone's been affected themselves. And there is this amazing, I know we say it over and over again, but neighbor helping neighbor effect that happened. Folks came out, these community health workers, our HOP staff, they were out before there was a way to drive anywhere. They're in the neighborhood. They're going knocking on doors. What do you need? What do you need? What do you need? Folks were sharing resources through a bullhorn at a town hall because there was no connectivity. It's hard to really paint the picture of no electricity, no cell phone, no internet, no water. And this went on for weeks and months. And so these networks, the community health workers, the HOP network, other networks that as a funder we had either played a part, learned about, or helped create a number of networks. And I'll give you an example. We had another network of our rural farmers who this network helped support our rural farmers and supported these community centers just throughout Sandy Mush and, way out in rural areas. And they were able to connect with the HOP network to find the farms that had not washed away, that had produce available. And then they worked through our food hubs and through our community health workers and our HOP delivery folks to get that local food that was sitting there was going to be wasted to the people who needed it before there was a way in or out of Western North Carolina. So these networks, building them ahead of time and thinking about the importance of hyperlocal and relationships is a part of the resilience. Mm-hmm. The other thing I wanted to mention about the resilience, and maybe that ties a little bit more into policy, is the fact that the HOP was really an established, sanctioned, and funded infrastructure. Mm-hmm. And so we talked about the challenge of connectivity and data, but it was really important that HOP wasn't just in Western North Carolina, it was elsewhere, and there were state and national connections. And those connections came to the table to help with the data collection. This is a pretty heavy data intensive, organization, endeavor, as many governmental things are, right? And so in order for the folks who are doing this work, who were just out there doing it, not thinking about a paycheck, our economy had shut down, they were able to help document what was being done. And so that $500,000 came in reimbursements for that work that was done. And I don't know, I might go as far to say this might be the first time that Medicaid was on the ground directly helping in a disaster relief effort. It was pretty incredible.
Yeah, and maybe Bill, coming to you, and then if Cody, if there's anything you want to pick up on what Susan was saying, but in thinking about the healthcare infrastructure, sort of the network of the MAHEC clinics and the residents that are being trained out in the western part of the state, sort of thinking about where does the healthcare delivery system intersect with these community health workers and some of the local networks, and then how to think about scaling and sustaining some of that infrastructure, even in kind of these more resource-constrained times that we find ourselves in.
Yeah, it was interesting to me, the layers of response. So, and the nested and intertwined layers. And I don't know what the right analogy is, but I keep going back to Venn diagrams and more complicated social dynamic structures. But when the storm hit, obviously the first thing, quite honestly, I'll share a very personal story. I was wildly unprepared for this. We all were, okay? But I was like wildly unprepared as leader of an organization, to the degree that my wife woke me up on Friday morning and said, the drain in the backyard is not, we can't keep it flowing because there's too much debris on it. This is at 7 in the morning, right as the storm is hitting. And I'm like, why are you bothering me? This is not a big deal. Little did I know. You can disagree with me, I know. And,
No, I agree, you weren't prepared.
Yeah, totally unprepared, right? We had closed our clinic, but like totally no expectation or understanding what was gonna happen. And I'm getting text messages, because we still had cell coverage at that point. Are you guys okay? Are you okay? Well, I didn't have any electricity or access to the world except for that. I'm like, what's the big deal? It's another storm, okay? So that first layer, my little snow globe, we lost some trees. I thought, how bad we lost some trees, this is terrible. Next layer, I go out in the neighborhood. Oh, the neighborhood was hit pretty hard, that's bad. And then it was like an unlayering of onions as things happened. And we all immediately, our first response, of course, was take care of family, take care of neighbors, that immediate local response. And then those of us who had an organizational responsibility, and I happen to lead an organization that I've described as, we're not first responders, but we're 1.1. And it was the relationships with Cody and others across the state, the relationships locally. Avril Pinder, the Buncombe County manager, who was on my board, who I got to know during COVID, called us up and said, hey, we got an emergency shelter established on the AB Tech campus. They need some help, can you go check it out? So that was Sunday morning, and I drove over there and immediately found a family practitioner who had been there for 36 hours and was distraught. She had 70 patients. They had an infrastructure of beds and electricity and generators and porta potties, and no one locally who knew how to deliver the services in the context of how does our community work. And so I went there, and we were out of the water, right? Like, our buildings were shut down. We had no potable water for 6 weeks. We had no electricity. We had emergency generator backup, but we could not deliver the care locally. And we had outside organizations coming in droves with pop up this and pop up that, and we had more bottled water than, I'm sure we still have bottled water up there from last year. It was not an issue of supplies at that point, but it was that, so we had this network of people who knew how to respond to disasters. And I see Dr. Perlin here, and I think about HCA. HCA is spectacular at responding to disasters because of the size and scope of their organization, what they've had to do, and they did a spectacular job. And then we had our local network of people who knew how to work our community to make that infrastructure work in the context of what our people needed. And that included our team, who went and staffed the Swananoa clinics and all the pop-up clinics. It included the Healthy Opportunities service providers who we interfaced with, especially the community health workers who helped us do home visits. It included the financial resources of Dogwood Health Trust and others. As an example, we received a $3 million unrestricted operating fund grant from Dogwood in the immediate aftermath of the storm, which allowed us to continue our payroll for 2 payrolls. And what that did was put our people at ease, let them go to work, do the work they were doing serving the community. So it was direct relief, not just to our employees, but an amplifying effect throughout the community so that we could do our service. So I think of these interconnected layers of networks that were all critically important, but really dependent on personal relationships as much as anything else.
Yeah, no, thank you. And Cody, I did want to come back to the piece about the state support in this and sort of the Medicaid infrastructure and the payments to the Healthy Opportunities pilots that help sustain a lot of these organizations, but then also, you know, pointing to some of the things that Bill was just talking about and leveraging kind of the healthcare infrastructure and all of the both chronic disease management in the aftermath of the storm, but also some of the infectious disease things that were like emerging after the storm. So I don't know if there's anything you wanted to add there in terms of the state supports kind of coming in and disaster response and thinking about community resilience in that regard.
Yeah, a couple pieces. One, I think Bill did a beautiful job of outlining, you know, we often think about kind of the layered approaches to a disaster response. And I think perhaps similar to COVID, what made Helene so challenging for us was that for Western North Carolina, it was a very novel experience. There are two communities in Western North Carolina that in particular fared a little differently by my observation. I went to every single county with the governor pretty much within the next 3 days after the storm cleared. And you know, right outside of Asheville, we had Tropical Storm Fred go through a couple of years prior. And in those communities, they did things like, oh, well, we saw the storm tracking, we figured it was going to hit us, we moved everything in our business from downstairs to upstairs, and we opened the doors and the water flew through, and we washed the walls down, we're already ready, right? And so that to me underscored an example of what a community that had been frankly hardened by a really tough experience a couple years prior could be prepared in a way that was different than people who were generally unexpected and had never seen anything like that before. Now, sadly, you know, Tropical Storm Fred's kind of impact around flooding in that area was much more limited than other places. So we didn't have as many people with that personal resilience and readiness and what to expect. And then you go to the daisy chain of local government and their readiness, and then the state reach. I think from a health infrastructure, and you mentioned HCA, I think it's a beautiful example of the work that they did to kind of do their national reach back and everything they brought to bear. But you know, from a governmental response perspective, you know, it takes us a handful of minutes to get the semi trucks up 95. Or to land, and you know, I always tell folks you don't want the semi trucks parked in the disaster area because they wash away with the storm, right? And so you want them to be a little bit out of pace. So you're almost always relying in some way on some natural local resilience. And what this storm tested was how long that could stretch. And I think so there was some learning there. I think there was some personal learning that people had. And they'll be ready with we got a new French drain.
Yeah.
But
I learned you can pop the drain out with a screwdriver, and then everything just flows like a toilet.
You're gonna do so much faster. Done, flush. So, but you know, taking this back to the kind of health system policy level, I mean, we do all the things naturally around, you know, increasing certain Medicaid payments, Appendix K waivers as part of the Medicaid program, relaxing how parents can get paid to do direct care for their folks that live in their home that are dependent upon direct care for Medicaid services. We also brought our payers together and our managed care partners to have them float certain claims and to prepay things, to turn off all prior auth. You know, we had I remember getting a call in the middle of the storm about a certain PBM not authorizing pharmacy payments, and we luckily knew the right person to call, and that got fixed in a second. But you know, so there's a significant amount of reach back and coordination, and all of that stuff happens. You know, that's the more routine aspects, and there's a playbook, and we kind of go through really fast. In this storm, where everything log jammed was at the local connection, that coordination piece. We had gluts of water bottles and gluts of food supplies and various things in the wrong places, getting it up the right place to the right community. And that meant, you know, having healthy opportunities. It meant healthcare infrastructure coordinating and sharing together across the state. It also meant, you know, whether it was FQHCs and community health centers, and we had pop-up community health centers happening in a variety of places, and so relaxing things to make that possible as well.
Well, now I have a couple questions for all of you, but and Susan, feel free to build on that. But you know, all of you are speaking from your experience helping guide organizations and response in the western part of the state. And so just wanted to know, like, what are some of your other, your big takeaways from that experience, apart from, drain maintenance? But what key aspects of the Healthy Opportunities pilots can really be emulated to address local and bipartisan community health challenges presented by similar climate-driven disasters, and kind of thinking about, building on Cody's points, what are some of those policy supports that are really needed to do this work in an ongoing way? And just, of course, acknowledging that pilots were stood up. We've talked about this, I think, but making it explicit. They were stood up for a very specific purpose in the Medicaid program, but have been critical for disaster response. So kind of what are some of your big takeaways, and what do you think are the kind of key ingredients that can really be emulated for doing that local bipartisan community health response?
Well, I'll be happy to kind of build on what Cody was saying. I do think that as communities, I don't know that a community that's never had this, it does not on the coast, is not in a place where you're kind of expecting and you evacuate and practice that. What we learned in Helene is it can happen anywhere. And it's hard. You mentioned, the Crusoe area and, where they had that flooding and they built some resilience. It's hard to imagine that you're going to have to do that if you haven't been through it. But I think what we're seeing, with the changing climate and things that disasters are becoming more severe and they're happening in unexpected places. And now we have learned what a hurricane looks like in the mountains. It turns into mudslides. And, I don't think that people living up on mountains, I was up on top of a mountain, thought I was safe and had a tornado come across my house. You wasn't expecting that. But I do think that in terms of municipality, county, and connected to state and even national pre-planning, thinking about it, thinking it can happen here, can really yield dividends in that. And that planning can be, instead of building something, it can be looking around to see what you have and thinking about how you might use the networks, the relationships that you have differently in a particular circumstance, a disaster. And that's what I think was so helpful about having the Healthy Opportunities Network. It wasn't designed for disaster response, and yet it was so incredibly helpful to have a mechanism. Soon we couldn't get funds flowing immediately, but soon as we could, to get them out to folks, so that, as Bill mentioned, folks who were kind of out doing what they needed to do, essentially volunteering to do this, would know, okay, we've got a paycheck, we can get, the reimbursements to do this work. And I think that was really critical and added a really important element of hope.
Yeah. The big learnings for me were not to underappreciate the value of preparedness. We've all done tabletop drills, right? Like, how many tabletop drills did I do as a CMO for active shooters or chemical disasters or whatever? And you get to the tabletop part of the drill, you say, well, right now we'd call in the pulmonologists and they'd come in and do their magic and put people on ventilators and everything would be great. And you never say, okay, who's got their numbers? Who's gonna make the phone call? What are you gonna do if you don't have electricity to make the phone call? We take it to this superficial level and we don't take it down deep enough. And so I as much as I hate that kind of stuff, like, it's just anathema for me to be preparing for something that I don't think is gonna happen, I now appreciate how valuable it is and how deeply you need to go to really be prepared. The second thing I really learned was the value of relationships, as we have talked about. I remember on the following Monday, so it was 9 days into the storm, we had total chaos. No one was in charge. We didn't know who was making the leads and the calls. And we had no connection with the DHHS folks on a regular basis. The major hospital player in our system is Mission Hospital, and they had a twice-a-day call, and I sat in there. But that was they were looking at a very minimal part of the community. And so understanding like who is going to be the coordinator of the communications and the decision making when there's so many different entities involved. And I don't think there's a simple solution for that, but that's important. And it's really helpful. Our most valuable employees were those who weren't in our community, who evacuated and then were able to coordinate it from afar because they actually had ongoing access to internet and information and a variety of other things. So the value of really understanding the importance of communication was super critical. And then the other thing I learned, which was very important, was I'm a cardiologist by training. I'm a physician. I've been trained to think independently, and I've learned over time in my changing roles the value of team-based work and working in teams. And I'm a convert. I'm not like most cardiologists, I guess. Flashbacks to meetings I had here with Rob Califf 40 years ago. Empower your people to do the right thing, trust in them to do the right thing. It's better to beg forgiveness than to ask permission in circumstances like that. So there was a lot of that we did. Someone said, can we send people to this clinic? If you have enough people, send them to the clinic. Let's get it done. Trust your people.
Yeah.
I'll just add a few thoughts on learnings, and I feel like I'm kind of like unhinged because I'm not working for the state anymore, so I can say whatever I want. But one, and this is like a policy thing that's maybe sidesteps this question, but I think it's fundamental, and Bill, your comment inspired me to say this, which is North Carolina's disaster response framework is built on a county-led model. The county is in the driver's seat in North Carolina for most things, frankly, but for this in particular. And the state's only supposed to step in when the county can't meet the need. But in this storm in particular, I think it highlighted, it wasn't just individuals who were challenged with individual response. We had disaster response leaders who are wonderful and talented and very good at all the things they normally do who had never seen a storm like this before either. And so, and the state apparatus, the response system, the tracking of the resource request, everything, none of it is built to supersede the county.
Yeah.
And yet we had a situation where nobody could get the person down the street in Asheville, but you could get me. And so we had to figure out this redundancy. And I mean, my phone was blowing up with calls from every legislator who had heard something, needing something, everybody who wanted this, that, or the other. And so then all of a sudden you had no water bottles, you told 6 people, and then 700 water bottles arrived, right? And that was so wasteful, right? Because it wasn't locally coordinated because of the communication challenges, because of the experience with the storm, the scale. And so I think from a policy design, and that is often at odds with, frankly, how healthcare works, right? Healthcare is so big now and is so managed at, if not a state, a national level or a multi-state regional level, that tension of trying to figure out how to coordinate these large entities and these smallers and that, I think is something we have to reconcile with from a policy design perspective going forward.
So we saw that same problem in COVID, right?
That's right.
Like when in our 16 county region that we're responsible for, 18, 20, however many, there's the haves and the have-not counties with resources and intellectual capital and financial capital. And we saw that COVID response was driven at a county level, as public health is in our community. And we didn't change anything, right? And then we saw the same thing now with COVID, or with Helene. So you're not in government anymore, so you're not very helpful to me right now. How are
Normally this would end with Bill saying, so go fix it.
So what are we going to do? How are we going to learn our lessons? If this is about learning lessons and changing policy, what the hell are we going to do?
I think there were a lot of changes, but there needs to be more. But
I disagree.
Yeah, I disagree. The only other thing I would say that's going to maybe be an inch more actionable is on, the sharing of data. Like we paved a lot of paths on being able to and continuing to replicate and make sure that it's accessible for folks through this, I think, is another important thing going forward.
And I mean, you brought up the redundancy, right? Redundancy at different levels, because what we didn't anticipate was being completely cut off. And there's no way you can prepare for that, and you can't do anything about it if you have no connectivity. We also had some staff that were out of the region, and then the connection with the state, that redundancy is very important. And if I can, I just wanted to say one more thing. I thought back to the very first conversation today, and several people brought up our most vulnerable populations, the folks who are often left out. And I think about policies that are focused on bringing them in. And what we've seen, and it's not unexpected, that in a disaster, the folks who are often left out get further left out. Especially whether that's our very rural communities, whether that's populations who just have, not had much investment, don't have a lot of connection. And so I think in preparing or thinking about how we might respond from policy issues is thinking about those populations in everything we do, the networks, the normal, and in our disaster preparedness.
That's great, and I think maybe, I want to leave a minute or two for any audience questions, so I'll let Susan perhaps have the last word on the panel discussion, but really appreciate the conversation on the importance of sort of investing in those relationships and sustaining those over time, the challenges that are presented when, the worst possible situation happens that you've never prepared for and wouldn't know how to even conceptualize in terms of the protracted loss of communication, but the work that was done in collaboration with all of these really important community leaders in healthcare and community health workers and community-based organizations and state leadership and local leadership. So appreciate the role that you all played. Any questions from the audience? I see one straight ahead. Please come with the mic.
Hi, my name's Chloe. I'm an undergraduate senior studying environmental science and policy. And so resilience has become this crazy buzzword, right? And I think if you asked people in here what their definition of resilience is, people would say different things. But to me, what it's not is elasticity, right? Like, we're not trying to have an impact happen and return to the same shape that we were when we began. We want to return to a different shape that's stronger. So I was wondering if you could give some tangible, specific examples of either actions that have been taken since Helene to return to a different shape, or specific examples of what you want to see done to make sure that if this happens again, we don't face these same challenges over and over.
She gets the best question of the day.
Yeah, that's great.
Really good. I have one immediately off the bat, and it's brief. So there's something called Medicaid stabilization payments that the Medicaid payers are supposed to be able to provide practices when there is a major issue in terms of seeing patients. We had zero ability to see patients for over a month, and yet they got the money from the state to take care of these patients. There was no demand on services, so their profits went up and our revenue went down, direct correlation between the two. And it took us 3 or 4 weeks of lots of back and forth to try to figure out how just to get that cash flow. And we needed that cash flow to keep our employees guaranteed employment, keep them going so they didn't leave the community, especially at some of our lowest levels. So a better understanding of how to quickly flip the switch and put obligations on them. The state's giving them the money to serve these people. These people suddenly can't get care, and it's just a windfall for them. That dollar should flow to us.
It's actually, I'll add a little bit more color to that. It's a great example. North Carolina has multiple managed care plans, and we actually saw where one of them decided that they were going to look at providers' past billings over the last X period of time, average it out, and just make payments, no questions asked. And it was really interesting to see kind of the competitive effects between that MCO versus the other 3, and it was lots of screaming in a meeting. But I agree that getting the dollars out to folks, and like a lot of people, I think that also underscores the importance of a playbook, of people understanding what to expect. One of the learnings that we had, and I alluded to briefly earlier, was, and I wasn't kidding, like we actually did have to broker a couple of truces with local militias that like rose up in response to the storm. And we had deployed out kind of local response, kind of government, essentially a nurse, a doctor, and whatever, in a little mobile clinic, like think MASH. And I think in those situations, one of the things that we had to go in with a local sheriff and a local firefighter, and it was less about their roles as law enforcement and more about their roles as a known entity in the community, because just to mention like the cultural elements here, like really were not welcome in the community. And when like the bridge washed out, some people were like, "Great, we're seceding from the union." Like it was an interesting dynamic to go through, and being ready for that is a harder thing to do.
All right.
Other questions?
I mean, the only thing I would add to your question about building that I think is a challenge, and I think there are some broader than in the healthcare delivery system, but there are policies, federal policies about how dollars can be used. And those dollars can be used to build back what was. And, so if there are many communities coming together and putting together their resilience plans and how we can build back better and stronger. And, one, it's hard to get the dollars flowing to start with. And second of all, those dollars are tied to certain criteria around how you build back. And the other thing I will say, and this comes back to understanding the culture, is how much is tied into our place. Our place is so much of our belonging. And so if, where you grew up and where you lived and your grandparents and great-grandparents, is now in the bottom of a river. It's like, well, what happened, there's all the legal things, what happened to your property, but then you're told you can't move back there. That's really a challenge as well. So trying to balance, that understanding of what the place means and where people are living, whether it's in a floodplain or not, how can they rebuild their home in a way that it won't be washed away the next time? It's a challenge.
Well, thank you all for your time and the questions, and I'm sure we'll have opportunities to connect more. So,
Rebecca, you had mentioned that I could have the last word. Can
I
have
did.
the last word?
Do it. Yes.
Now, we have sort of painted a picture of Western North Carolina as a place that you may not think you're welcome to come visit.
Come visit.
Please, come visit. Western North Carolina is open for business and would love to have you come visit and spend lots of money. Please, please, please.
Susan has arranged for a bus to take you outside right now.
We're heavily tourism dependent. Come.
The leaves are going to be
Ideally, spend a lot of money.
Yeah.